Okay, first of all, a disclosure. Radical prostatectomy is what I do for a living. It's the most common surgical procedure that I do. I did do some HIFU. HIFU, by the way, is High Intensity Focused Ultrasound. For those of you who don't know about it, it's a technology that's been around since the late 1980s. And it focuses ultrasound energy on a tissue and heats it up so much that the tissue is destroyed. Basically just coagulates it. I used HIFU in the early 1990s and published with my colleague Lawrence Sullivan at the time on the use of HIFU in BPH. And our conclusion at the time was it's a long haul for a short slide. It took about an hour, hour and a half to get a little bit of prostate tissue destroyed, which I could do with a standard resectoscope. Some of you may have had the resectoscope, the TUR or the Rotor-Rooter or whatever, in 5 minutes and getting a better result. So we sort of abandoned it at the time. And then it came back and it was being marketed, particularly in Europe, in Germany, France, and in Japan, for the treatment of prostate cancer of all stages. Early stage, late, local stage, with treatment-naive patients, as well as in radiation failures. And there's been a lot of data published, and I'll address some of that. But the title of my talk is really HIFU or HIPU, because there is a lot of hype, there's a lot of marketing that is clouding the whole issue of HIFU, which is unfortunate because, as I say later, I think this is very interesting and potentially strong technology. The National Institute of Health Research in the UK, their Health Technology Assessment Program in 2003, and this statement remains on their website as in 2007, I haven't checked since last October. Owing to the paucity and poor quality of evidence identified for the remaining interventions, this is after they were talking about brachytherapy, I believe, hormonal monotherapy, HIFU, IMTT, RITA, which is radiofrequency, laser photocoagulation, and gene therapy. Conclusions regarding their clinical effectiveness cannot be drawn. It's just too early, basically. Don't have enough data. And there were this was the largest study that was published back in 2003, and it had 652 patients. This is from Germany, from Mainz. 400 of these people had localized disease, what we call T1 or T2 disease. The median number of HIFU sessions was 1.4. 288 out of the 402, I don't know what happened to the others, had biopsy data, and 87% of these 288, which is a subgroup of the total group, had negative sextant, means 6 cores. And as you know, we don't do 6 anymore, we now do 8, 10, or 12. And 212 out of the 402 had more than a 6-month follow-up with a nadir of 0.6. So that was it. That was the hype. But I point out to you that data, which is the largest multi-center study that's published at the time, the data was analyzed in 1999. It took them 4 years to publish it. And during the 4 years of publication, the treatment frequencies, the frequency of the ultrasound increased, the time, the duration of each shot of radiofrequency increased, the number of planned sessions decreased, and they had a number of other modifications that improved their results, and they selected smaller prostate glands. But since there's no greater than 10-year data published since 1999's interim analysis, and I believe we're now in 2008, so I'm just wondering, where is the data? So let me tell you about Health Canada's and medical device license. I know Stephen, some of my talk is going to address some of the points that Stephen Strum made about how we introduce diagnostics and therapeutics into our society. Canada has Health Canada, and we approve drugs through Health Canada, but we also approve devices. Bottom line is, this device, which is basically was put forward as an ultrasound machine, because that's what it is, and ultrasound machines are approved. It was licensed as Class 3, meaning potentially hazardous under the Medical Device Regulation Act. 1 is a low risk, 5 is a high risk. So this was sort of classified. It was licensed, but as Class 3, with no reference whatsoever to investigational testing. It was based basically on design and manufacturing meeting the Canadian standards, safety standards. They had a listing only, not a review, just a listing of published reports addressing effectiveness and safety. and that basically the quality of the manufacturing system satisfied the national standards of Canada. Essentially, it was licensed on the same grounds as a hairdryer. I'm not being critical. As I said, I'm quite open-minded about HIFU. We did a technology review in Vancouver. We were asked to do this. Tom Pickles, who's a radiation oncologist at our cancer agency, myself, and Gary Steinhoff, who's a community urologist in Victoria. We reviewed the literature at the request of the College of Physicians and Surgeons of British Columbia. And the reason we were asked to do that is because a private group, Surgical Center, had requested permission to bring HIFU into their hospital, into their clinic. In British Columbia, the College of Physicians has to approve all surgical procedures done in private centers. That's not the case in Ontario. I'm not sure about the other provinces. The reason I mention is because, as you probably know, HIFU is available in Ontario. And that's because their college was not in the loop for licensing. So the college requested that the cancer agency, the three of us, provide them with a literature review and an opinion. So we reviewed every piece of literature that we could find, and it actually was published in the Canadian Journal of Neurology a few years ago. And the key points were that we published the worldwide literature up to December 04 at the time. There were no randomized studies. A randomized study is when you have a new procedure or a new drug, and you want to compare it to the gold standard. So half the men in the study are randomized to the gold standard, or the accepted standard of care, and the other half are to the novel drug or the new device. And then there's statisticians tell you how many people need to be in both arms depending on what kind of differences you expect. It's all statistical calculations, and then at the end of the day you compare and you say there's a statistical difference, that it's better, it's worse, it's the same. So there weren't any randomized studies, just case series. So I'm a physician I've got my ultrasound machine, and I'm going to do 100 patients and write up the results of the next 100 men who come in and have ultrasound. That's okay. It gives us an idea of efficacy. It's what we call phase 2, where you determine that there is efficacy and safety as a preliminary to going on to a randomized study which compares it to the standard of care. And unfortunately, we could not really figure out the true numbers, because when you dig deep into all of these studies that were in the literature at the time, there were data sets that were duplicated. So Dr. X would publish on 75 patients, and then a year later would publish on 88 patients or 95 patients that included the first 75. So the database was just expanded, it wasn't increased. Yet the companies that are marketing it would have added those up to 75 plus 95, as opposed to just 95. So it gives the appearance that a lot more patients have been treated. The follow-up in all the papers is relatively short. Now remember again, this is 3 years ago. And completeness of follow-up was not documented. So the mean follow-up was less than 2 years. And as you all know, for prostate cancer, we need longer follow-up. It's a slower growing disease. The technology kept changing. The currently available device was only on the market in the year 2000. There is lack of disclosure. Some of the authors had clear conflicts of interest. They were on the boards of the companies making the machines. And most studies reported mean rather than median follow-up. Statistically, is a big difference. You can cook your numbers a little bit that way. So PSA nadir, the lowest PSA, is dependent on prostate size. The true PSA relapse rates are likely underestimated, as some of the patients did not have adequate follow-up time for the required 3 rises. There's an ASTRO definition, is the definition of failure following radiation. ASTRO, which is the radiation oncology group in North America, they decided a number of years ago that the definition of failure after radiation was 3 sequential rises of PSA. They have changed that now to what's called the Phoenix classification, which is the nadir plus 2. So you let the PSA go down as low as it'll go after radiation, and if it increases by 2 or more, then that's considered a failure at the point that it reaches that 2 nanograms more. Because remember, the prostate is still in. Unlike with surgery, where you've obliterated the prostate, you removed it, the PSA should go to 0. With radiation, there's still prostate there making PSA, so it won't go down. It'll go down low in some and very low, but it won't go down to 0. One of the issues that we had was, how can you take a radiation definition of failure and apply it to a procedure that is being touted as an obliterative procedure? They're saying they can obliterate the prostate. Well, that's what I do with my knife. I obliterate the prostate. And I have a definition of 0 for failure. So there are issues of endpoints, basically. We had no data whatsoever on what would you do if a man failed HIFU. The companies say, well, just repeat the HIFU, but there's no data on that. Or what about operating to remove a prostate after HIFU has failed? And is that easy to do? We know that operating after radiation therapy is wrought with problems, but we don't know for HIFU. So we can't tell our patients, well, don't worry about it, if it fails, we'll just take it out, or we'll radiate you. Okay? The early and late toxicity was not insignificant. Okay? There were fistulas, there were problems with urethral strictures, and a lot of bladder irritation. So there were problems. It's not a walk in the park. I wasn't taking an aspirin tablet. And a lot of the patients, almost half of them, had hormones. And as you know, it takes a while for the hormones to wear off. When you're on intermittent therapy, or if you received hormones with radiation or surgery, it takes some time. And it could be as long as a year or even more, and that wasn't taken into account. So if your testosterone data isn't presented, isn't part of the evaluation, you really can't assess the PSA value. Because if you don't have testosterone, your PSA is going to be low, even if you have active cancer. Does it all make sense? So our conclusion in that report was a lack of efficacy data does not allow meaningful assessment as to the benefit-risk ratio of HIFU. It would therefore be inappropriate to offer HIFU as standard therapy for prostate cancer, and it should be explored in further research settings, i.e. show me the money. So since then, that report was, as I mentioned, a few years ago. There's been a lot of research, a lot of studies done on HIFU, and they've learned a lot about how it works, whether it's the cavitation, it's blocking blood vessels, and there's an immune response to cells that are broken up and what are called antigens, or proteins are released, so you can, the body reacts to these antigens. And so there's a lot of theories now as to how it works. And as I said, and I repeatedly say, I think this is technology that needs to be further assessed. I think it's great technology, it's got great potential. But again, over the period of time, from the 90s to current day, the hardware keeps changing. So it keeps, they're basically, what they're doing today is they're saying, here is the efficacy data, okay, based on the improved hardware and software. No, I'm sorry, this is the safety data based on today's hardware and software, which is safer. And the efficacy data from the older hardware, which wasn't as safe. Okay? In other words, they're mixing apples and oranges. So the transducers are better. And one of the companies, the Abiraterone company, is recommending that a TUR or a rotor-rooter be done before the HIFU. More complete treatment each time with less retreatments, use of antibiotics. The next two bother me a little bit. They're leaving a 5 millimeter margin at the apex of the prostate where it's right against the urethra, because they were getting some incontinence. So they're recommending that you leave a 5 millimeter margin there. But as we know from surgical series, the apex, that tip of the prostate, is where the highest percentage of positive margins is. That's where the cancer is. So I'm not quite sure how you can spare that and still say you've treated the whole prostate. They're doing nerve sparing because a lot of patients did develop nerve damage and impotence. So they're leaving a rim of prostate next to the nerves. Again, that's where the cancer is in many men. So I don't know. Rectal cooling, that's been good because it's eliminated fistulas to the rectum, which are terrible, really catastrophic complications, and so forth. They're using different ways of being able to ultrasound and see the prostate so they get better applications. So it's a therapy in evolution, better functional outcome, but is therapeutic effect diminished? It's too early to know. And I'm just going to skip through the NIH, the UK's database website. Just go to this. The new data that's published since 2005. There are about 5 different series, one from Japan, one from France, Italy, England, and Belgium. You can see that. They were all published in 2006. The Japanese series of looking at this is looking at PSA for patients with low-risk disease out to 5 years. Fantastic. 94% of the men, okay, are showing biochemical-free recurrences. In other words, their PSAs are down to 0 and staying there. These men were low risk, okay? They all had 0 to 10 PSAs when they started. The middle intermediate group, who had PSAs of 10 to 20 with low risk local disease, they're at about 75% at 5 years. And the high risk patients with higher PSAs are at 35% at 40 months. I believe that data. The French data, same thing. I'm going to just go through it because I do want to have time for my last talk. Again, what this shows is that for people with low-risk disease, men who have very low PSAs, they got great 5-year data. Now, it's actuarial, meaning it's not real. Not every one of those 50 men has reached 5 years. It's projected, a statistical projection. People with intermediate PSAs, 57%, and 10 to 15, 61%. So you can see that there. Men with a low Gleason score, 66%, Gleason 7, 67%. So keep those numbers in mind as you look at the next couple of slides. This was published by Johansson in 2004, and this shows the natural history of untreated localized prostate cancer. So these are men who didn't receive HIFU, they received nada, okay? And at 5 years, the results are the same as I just showed you on those preceding slides, okay? And one more example, Peter Albertson. You've heard about nomograms. Peter Albertson is really a very logical thinker. He's a wonderful physician. He's really studied this stuff carefully, and basically what he's shown is that there's a surgery in the red, radiation in the blue, and observation alone in the black. You can see for low-risk disease, this is out to 15 years. Most men are well above 80 to 90% survival. So these men really don't need treatment. This is the basis of active surveillance, as was alluded to. We have, in my group, we have about 150 men, and I think Laurie's series is up to about 500 or 600 men. And all around the world, UC San Francisco's got a large series, Memorial's got a large series. Based on this data, these men don't need treatment, they need observation. So you have to keep that in mind when you're looking at the data that's coming out from these HIFU series that are actuarial 5-year results. They're showing really good results for early stage, but only modest results for higher stage disease or higher risk disease. And it always comes back to an oncologic therapeutic dilemma that was written by Willett Whitmore, who was one of the greats in uro-oncology. He was the head at Memorial in New York for many years. He eventually died of prostate cancer himself because he had a stage 2 disease and elected to do nothing about it. And unfortunately for him, it did kill him eventually. And he asked, is cure of prostate cancer possible when it is necessary? So people with high-risk disease, who we know will go on to develop bad disease, metastatic disease, and eventually possibly die of prostate cancer, can we cure them when it's necessary? I think we can, by the way, if we catch them early. And congratulations to you for here in Calgary for the PSA awareness campaign. But the second more important question is cure necessary when it is possible? So if I take a man with a low grade, low PSA, little bit of prostate cancer, do I really need to take his prostate out? Is he going to die of it? It could be 15, 20, 30 years before it becomes life-threatening. Why not just sit tight and watch it? Same thing applies. So these are thoughts, my thoughts, on what we need to think of when we look at this data on HIFU, and why I'm not automatically recommending it to my patients. Now, if people ask me about HIFU and should they go and have it, I basically say the following. It's an emerging technology with exciting potential, but there's also risks of overtreatment, and you may be overtreated and get side effects. Treatment efficacy correlates inversely to tumor burden. The more cancer you have, the less effective HIFU will be. The less cancer you have, the more effective HIFU will be. Precise patient selection and adherence to technical details is crucial and still somewhat uncertain. We don't know about that apical sparing and the nerve sparing. Yes, treatment can be repeated. No bridges are burned. That's what the companies and the people who are using it are saying it. Is it as curative as a radical prostatectomy or radiation? We don't know. Is it less morbid? We know it's not a magic bullet. I think that it could be in the future positioned that HIFU is an alternative to standard therapy for those who are unsuitable or who are not interested in having standard of therapy, standard of care therapy. It may be an alternative to active surveillance in very low-risk patients. Some men just can't cope with the C word and the idea that you're not doing anything. I have cancer and you don't want to do anything? Are you crazy? I want HIFU. Perfect. I'll give you an aspirin too. Energy source for focal therapy. We're talking about focal therapy in our uro-oncology circles now. That is, if we can see the prostate well enough, and again, Stephen referred to 3T MRI. We have a 3T unit in Vancouver. There are not a lot of them in Canada right now, but there's increasing numbers around North America. They've had them in Europe for a little bit longer. To see whether or not we can see where the cancers are in the prostate. And if we could, they did this for breast cancer. You know, and there was a day where if you had breast cancer, even if it was a small little lump, you had a mastectomy, a radical mastectomy. But then Dr. Fisher and others realized that, hey, if that's the only tumor, we can just do a lumpectomy, remove that tumor, radiate the breast if the lymph nodes are negative, and that's it. We can cure lots of women that way. So theoretically, we can do lumpectomies of the prostate. And HIFU may be a good energy source. So if you can see the lump, destroy it with HIFU and leave the rest of the prostate alone. So I think that's a really good potential for this energy source. It may also be a good potential for cryotherapy or freezing or other drug injections and other ways of doing it. There's a thing called pulsed HIFU, which breaks up cells and allow drugs to go into the cells in a more efficient way. So HIFU may be involved in getting drug delivery into the prostate. It may be good for people who have failed radiation and are high risk for hormone therapy because of their cardiac history or to palliate locally advanced tumors. So there are probably going to be positions for HIFU, but right now I'd say buyer beware. But let me just talk about, for just a couple minutes here, on technology trials. I just put these slides in after listening to Stephen's talk this morning because I think that we have a big issue in medicine. On the one hand, we have all of these technological advances, and we have people who want to jump on the bandwagon and provide these to their patients because the data looks good and it looks promising and we don't have any alternatives, be it, for example, looking for lymph nodes in the body. There's some great work on that with the iron oxide particles and so forth and so on. But most of the trials tend to be underpowered. They're short-term, they're not randomized. Meta-analyses, putting all these things together, all these different data sets together, tend to produce from us, and I'm being a purist here, poor quality, statistically invalid with limited conclusions. Okay? Now I'm at an extreme here, okay? That's not me, but I'm presenting this as an extreme observation from one extreme. There are many examples of technological advances that have become extinct. I can list off, for example, with BPH, or benign prostatic hyperplasia, balloon dilatation, TUMT, microwave therapy, tuna, laser injection therapies, and on and on. And they were great advances, everybody jumped on the bandwagon, and they're not being used very much anymore. And I like to say the urology bandwagon has powerful shock absorbers from people jumping up and on. So once a device is approved, as physicians, what is our moral obligation to the public? Is it caveat emptor? Here it is, but beware, we're not sure. Or primum non nocere, to just do no harm. So we should hold back. And this is a moral issue. I think Stephen very nicely addressed the fact that, particularly south of the border, a lot of physicians have gone on the left side of that, to caveat emptor. And I think in Canada, most physicians think a lot more thoughtful and will primarily do no harm first. But each of us as a physician has a different threshold, a moral threshold and an ethical threshold. And there's all these pressures that come to bear on us as a physician when these new devices or new treatments or new drugs that you hear about and read about on the web and want to know, is that for me? Can I get that drug? I want that immune therapy. I want that new hormone therapy, whatever. You know, patients need to know. There's patients advocacy groups, the CPCN. Industry and marketing are going to be pushing us. Key opinion leaders are pushing us. Professional societies. And we have to balance that against levels of evidence. What is the evidence? We get it from the media, from the website, constantly. And of course, a lot of physicians are influenced, and their threshold is adjusted according to financial gain. And it refers to a lot of drugs, treatments for benign prostatic hyperplasia, for overactive bladder, for erectile dysfunction, cosmetic surgery, and now for cancer too. So these are the pressures that come to bear on us as a physician, and we feel that our obligations to the public they serve. We do have these regulatory bodies, and I have to agree the FDA is a slow-moving elephant for many of these drugs. But it's important to have regulatory bodies to protect us as patients and to protect us as physicians. The regulation of these things decreases, of course, as you go through from pharma drugs, devices, and so forth. So devices and diagnostics are not put to the same rigor of a test as a pharmaceutical drug is, which could take 10 or 15 years to get into the market. And even then, look at Vioxx. Came on the market, took years and years, and it's now off the market because post-marketing, they found cardiovascular problems with it. So just to sum up here, new therapies or new diagnostics, what do we do? What do you do? What do you look for? So there's a new idea, a new hypothesis. Somebody comes up with a great idea. It's got to be verified or falsified. And if you can verify it or falsify it, then you take the appropriate action. But if you can't, it's not always possible to verify it in fact or in time. You know, this device, Abiraterone, great looking drug, okay? It's not being really verified yet. You know, 23 patients is just not enough from the Johann van Bono. Now there's about 63 in total that Ari Belden was telling me have been treated. And they are going to do the studies. And I think Abiraterone has a lot of promise. But does it mean we just open up the floodgates and put everybody on Abiraterone and then find out later on that it didn't do anything except cost us money and toxicity? I don't know. So we're at this point in this conundrum. It's we don't know, but. So we don't know if it's a good drug, but it looks promising, so let's try it because you may not be around next year to try it. Okay? And then we always get, yeah, doc, but what would you do? I mean, that's a pretty standard question we get constantly. So as physicians, we have to function under the rubric of the art of medicine, and we have to call upon common sense to rescue us. Okay? I quote Oliver Wendell Holmes, certitude is not the test of certainty. We have been cocksure of many things that were not so. But as Paul Lang, who's was past head of urology in Washington, but usually they are true. And this remains an anchor of medicine by those practicing physicians who cannot afford the luxury of operational nihilism. We get sued, the FDA gets sued, the lawyers are always in the background. How many lawyers in the room? No, no. Okay, some of these lawsuits are justified, some of them I think are over the top. But it's a fear that's always in the back of one's mind. And as a physician, you think, geez, if I don't get this patient this drug, is he going to sue me or is the family going to sue me later on? It's there. It's a reality of our lives. So I'll finish with a quote of Peter Newman. Establishments abide not as they once were or should have been, but in the best Darwinian tradition. They mutate to fit the times, renewing themselves like snakes, the old body in a new skin. Thanks.